Hi everyone, my name is Jeff Dykes with CVTC's EMS and Fire team, and we're here to talk about Chapter 6, the human body. So for EMT1 and EMT2, the human body is essentially sort of a lesser version of an AMP course that maybe many of you have taken in the past, but it sort of talks about terminology is a big one in here, and just sort of understanding how the systems work. So without further ado, I will get my mug out of here. This particular chapter is pretty long. So this video is going to be broken down into 2, maybe even 3 parts. We'll see how it goes here. Let's start here. So we use different terminologies to describe where things are located on the body. And I always sort of get a kick out of it when I ask someone, well, where do you listen for lung sounds? And they say here. I always tell them you'll never see the answer here on a test. You have to be able to describe it. Where's the cut? Where's the deformity? Where's the pain? So here's some of the terminologies that you need to become familiar with. Anterior is anything on the front of your body. Posterior is on the back of your body. Superior is above another part. So your head is superior to your waist. Inferior is below. So your knee is inferior to your waist. So if someone's has a bad cut or a bone sticking out of their lower leg, you can say we have a deformity just inferior to the left knee. So those are some of the terminologies we use. Lateral is the side direction toward the side of the body. So your shoulder is lateral to your left breast type of thing. Medial is the middle toward the body. So your belly button is medial to your hip. Proximal is closer to the trunk, and distal is further away from your trunk. So if you had a laceration to your forearm, you would say that you have a laceration just distal to the elbow. So these are some terminologies that you're going to have to become familiar with, because this is how test questions are going to be described as you take your different tests. And when you come in for one of your classes here, we'll put you through the paces on these, and you'll have an assignment where you put a piece of tape just lateral to this or just on the posterior part of this, and making sure you understand it. So if you're a flashcard person, these are great flashcards. These are the different planes of the body: the frontal plane, the lateral plane, the transverse plane, midline, mid-axillary, mid-clavicular. These are also something that you're going to have to sort of put to memory. Midline is dividing your body into left and right. Mid-axillary is the one that comes right from your ear to your shoulder, down through your hip, and down to your ankle. So the mid-axillary line goes along your side here. Mid-clavicular. So if you take your clavicle attaches just off to the side of your neck, and it comes down to your shoulder. Most of you can feel your clavicle bone. Mid-clavicular is the middle of your clavicle bone, and it's a very common terminology that we use when we talk about where we're going to listen to lung sounds. We'll listen mid-clavicular, so you find the clavicle and you go in the middle of the clavicle, and then you go down 1 or 2 intercostal spaces, which is listening between different ribs, the second intercostal, the third intercostal, the fourth intercostal, things along those lines. So again, good flashcard opportunities to keep this in mind. Patient positioning. Very, very common. So if someone is found in the supine position, they're face up. If someone is found in the prone position, they're face down. Someone is sitting in the Fowler's position, Fowlers. I'm sure you've seen this in your book. They're in a sitting position. Semi-Fowlers is sort of the halfway reclined back look to them. The recovery position is demonstrated up here in the upper right-hand corner, where the patient's on their side, their top knee is sort of rolled over. We put people in the recovery position when we're afraid of them possibly, they're unconscious, we're possibly afraid of them aspirating or vomiting, and maybe we have to go call 911 or get a bag or something like that. The recovery position is a very common test question answer. And then you have these two here in the middle. So the one down below is the shock position. Someone's laying on the ground, we need to elevate their feet. This allows us to increase their blood pressure by just simply taking the blood in the legs, allowing gravity to do its work and push the blood back to the core organs in the head and the heart. That will elevate your blood pressure. But if someone has a spinal injury, we would not want to flex their spine like this person here in the bottom is. So we would put them in this position where they're on a long board or a cot, and you can see this lady's spine is completely straight. This is Trendelenburg's, Trendelburgs, maybe. Sounds about right to me. Trendelenburg's. So shock position, Trendelenburg's position. Again, drawing these out, put them on flashcards. I guarantee you're going to have to know these terminologies. Some simple A&P stuff. So flexion is the bending of a joint. Sort of as you see someone's flexing their arm here. Extension is to make it straight. Adduction is moving something toward your midline or toward your body. We remember adduction versus abduction is ADD is to add something, so you're bringing it toward your body. Abduction is taking something away from your body or away from your midline. Flashcards. Okay, the skull. So there's a bunch of different bones that all sort of make up our skull, and these are the main ones that we're going to want you to sort of have an idea of. There's going to be a diagram probably on a test where you're going to label these. The parietal bone is up on top of the head here. The frontal bone is the big forehead, if you will. The mandible down below is your jaw. The maxilla is your cheekbones. Zygomatic bone is sort of along your upper cheek, if you will. You have the temporal bone, which is very common to have some injuries along the side of your head. Occipital bone, when you fall backwards and crack your head on the ground, oftentimes we'll have some injuries to the occipital bone. I think those are probably some of the bigger ones that I would probably... nasal bone, the one that's up here between the eyes. Those are the main ones that I would want to make sure I know for a test question. Very strong chance you'll see a skull with some bones and arrows pointing to it, and you're going to have to label those out. Again, we have to know these, so when you're writing your report, when you're calling in to talk to a doctor, you just don't say, well, they got hit in the head, and I think they broke their face. It doesn't quite work in the EMS world. We have to tell them exactly what we think is wrong. If we were in class here, we'd have a little group activity here. Guaranteed to see this again, 3 different types of muscle. So we have skeletal muscle, often referred to as voluntary muscle. These are the muscles that move our bones, our biceps, our triceps, our quads. What we would traditionally consider a muscle that moves our skeleton around, those are skeletal or voluntary muscles. There's 2 other types of muscles that oftentimes we don't really think of as muscle. One of those is the smooth muscle, which is the blood vessels. Your veins and arteries are dynamic, meaning they can constrict or they can dilate. Those are intestines as well. We have that pulsating motion that pushes through food through our digestive system. So that's the second type, smooth muscle. And the third type of muscle is the cardiac muscle, which is the heart itself. 3 different types. Make sure we lock those in as well. Here we have listed out a bunch of the different muscles that we are sort of expecting you to know, very similar to the bones of the skull. We're going to have to know the different muscles. So most of these are fairly self-explanatory. Quadriceps, biceps, deltoids, traps, pecs. These are fairly common muscle groups that I think a lot of us maybe even know without taking the A&P class. One that always gets people here is the gastrocnemius, which is the calf muscle. A lot of people screw that up. So reviewing this, again, if you need diagrams, flashcards is a good way to go. Knowing the different parts of the spinal column. So we have 7 different parts of the spine vertebrae, C1 through C7 up here in the neck. Then we have 12 in the thoracic, which starts at the bottom of the neck and comes through the mid-chest. And as we move down into the back, we have 5 lumbar, 5 sacrum, and then 4 coccyx, which are also all fused together, often referred to as the tailbone. So one thing that a student told me a few semesters back that really made sense for them to remember this, it's breakfast at 7, lunch at noon, and dinner at 5 is how they sort of figured out, or it's a nice little way for them to remember how many vertebrae are in each one of the different sections. Then we have the bones. Again, a lot of fairly common bones in here. The ulna radius bone is in our forearm. The humerus is up here. There's that clavicle we talked about, probably the most common bone that is broken, the mandible and the skull. The femur is the strongest, longest bone in the body. We have our tib fib, the tibia is in the front, the little tiny fibia is along the back. This is the most common bone that has an open fracture, which means they break it and it pops through the skin, because as you feel down to your leg, you'll feel that that bone is right up against the skin. So as you have some type of fracture of that bone, it's very easy for it to pop through the skin, and that would be considered an open fracture, but we'll talk about that later on. Phalanges are doubled up. So phalanges are our fingers, but they're also our toes. We have our carpus, which is our wrist bones. We have our tarsus, which is our ankle bones. Our metatarsus is sort of the top of the foot. And then we move into the phalanges. So there will be probably a skeleton and some tape, and you're going to go through and you're going to label a lot of these different types of bones when you come into class. Again, flashcards. When you come into class, these are things that you should have reviewed, studied, and are ready to sort of perform those skills. Then we have the respiratory system. The respiratory system is broken into the upper and the lower airway. We're going to break them into two different groups here. So the upper airway consists of the nasopharynx, which is sort of the back of the nose area. We have the pharynx, which is the back of the mouth. The oral pharynx, which is sort of what we would consider inside our mouth. And then as they both sort of come together in the back of our throat, then they come down to the epiglottis. The epiglottis is going to be talked about in detail in class. It's a little leaf-shaped structure that sort of divides our esophagus from our trachea. Trachea being our windpipe, that attaches to our lungs, allows air to get down to our lungs. The esophagus is our food pipe, if you will, that allows food to get down into our stomach. The epiglottis is what controls that. So if you've ever taken a sip of something and it quote-unquote goes down the wrong pipe and it gives you that coughing spell, your epiglottis malfunctioned and allowed some of the fluid to go down into your lungs. Your lungs doesn't like that. You have this very violent coughing attack and it tries to expel that back out. The larynx is just below the epiglottis, and that is considered the voice box. So epiglottis and above is considered upper airway. And then once we get below the epiglottis, that's when we move into the trachea. So the trachea is in front of our body here. It's on. You can feel it as you feel the front of your throat. Behind your trachea is the esophagus, and that's your food pipe that goes down into your stomach. But since we're talking about the airway, not really our digestive system, we concentrate on the trachea here. The trachea comes down, and it divides into a left and a lower lobe of your lung. And the lobe on the left is going to be a little bit smaller. It has 2 lobes on the left side. It has 3 on the right. We'll talk about that a little bit more when we get into the airway section. $1,000,000 question is why, and the answer is because we have the heart on the left side, and the heart takes up some room, so we don't have enough room for all 3 lobes. But the air comes down the trachea. Where it bifurcates into the left and the right lobe is called the carina, and that's this part right here. You can see the little arrow pointing to it. So then you have a left and a right main stem bronchi, and they get smaller and they get smaller and they get smaller, and they branch out like very much like a tree until they get all the way down to the bronchi turn into bronchioles, and then at the very end we have these white sac-looking like features called the alveoli. And the alveoli is where we drop off the oxygen and pick up the CO2, and that diffusion takes place. The apex of the lung is considered up on the top of the lung. The base of the lung is down below. Sort of important to understand that concept because different diseases attack different parts of the lungs. So you can be listening to one of your patients and have one lung sound up high and a different one down low. The diaphragm is the muscle that sits below the lungs, and the diaphragm is incredibly important on the whole process of breathing. It usually does the opposite of what most people think it would do. Meaning, when the diaphragm contracts, the diaphragm gets very flat. And when it gets flat, it allows your lungs to expand. And when your lungs expand, it creates a negative pressure, which basically sucks in air. And that fresh oxygen then goes down to the alveoli. And then as your diaphragm relaxes, it goes back to its natural form, which creates a positive pressure inside, forcing the air out. And there's going to be a couple of videos for you to watch. But it's important to understand that it sort of does the opposite of what most people think. The active portion of breathing is actually the inhalation, because we have to contract this diaphragm. And then as the diaphragm relaxes, the passive part is the exhalation part. All right, another group activity. Some additional terminologies here for us to take a look at. Ventilation, respiration, and oxygenation. They're in your book. They become sort of tedious to understand the difference between them, but I think it's important for you to read each one and understand that oxygenation is different than ventilation. Ventilation is just moving the air. Oxygenation is actually moving oxygen through. You can be moving plenty of air, but if there's no oxygen in the air, you have great ventilation. You just have no oxygenation. Result is death, right? Diffusion is the term of actually the oxygen and CO2 passing across the membrane down in the alveoli. Hypoxic drive. So here's an important one. So our body decides to breathe faster, deeper, slower, shallower based on the amount of CO2 in our system, not the amount of oxygen. It's based on the amount of CO2 in our system. And that's sort of a hard concept for some people to understand. But if our body has too much CO2 in our system, our brain tells our body to breathe faster, because as we breathe faster, we are blowing off more CO2. If we do not have enough CO2 in our body, that means we have too much oxygen, then our brain tells our body to breathe slower and bring in less oxygen, because it has to allow CO2 to build up, because we're constantly generating CO2 in our body. So that's the main way our body decides how it wants to breathe. However, sometimes that does not work properly. So we have a backup system. Our bodies are these, massive computers that have all these different fail-safe mechanisms in them. The backup system is called the hypoxic drive. And the backup system is what helps control our respirations when our body can no longer detect or regulate the CO2. The hypoxic drive looks at oxygen itself. Usually if you're using your hypoxic drive, you're having some problems. So we'll talk about that a little bit more when we get to airway for sure. But it's a good concept to understand that CO2 is what drives our respiratory rate and depth and quality. Tidal volume. Tidal volume is simply how much air do I bring in with each breath. An average adult is going to bring in 500 milliliters of air. That's a sort of an important number to know. It also correlates exactly with the bag valve mask, the AMBU bag. When we used the bag valve mask, when we did CPR, that big yellow bag, that's exactly 500 milliliters of air, because that correlates to a tidal volume. So, fun stuff. The brain stem, so at the very top of the neck, bottom of the brain, that is what controls our breathing. That's where the sensor lives to look for that carbon dioxide, sort of like I just got done explaining. Brain automatically controls breathing. Yep, talked about that already. Talked about the CO2, so I'm a little bit ahead of myself, but I think we get the concept. All right, we talked about the diaphragm. So the muscles that allow us to breathe, the main muscle is the diaphragm. When you see this PowerPoint, you should be clicking on this. So this little blue thing here will take you to a really cool video. Click on it, and it'll take you to a YouTube thing that really explains the diaphragm very well. I don't want to do it here just because you can do that in your own time. In addition to the diaphragm, which is probably the most important muscle, we also use our intercostal muscles, which are the muscles that are in between our ribs that allows us to expand and contract our rib cage. Expanding our rib cage creates a negative pressure on the inside of our chest, then hence sucking in air. Those intercostal muscles contract, shrinking the space inside of our lungs, inside of our chest, which forces the air back out. But there's also some other muscles, the neck muscles, the cervical muscles, the abdominal muscles, and the pectoral muscles all sort of play a role in it. A lot of those muscles play a larger role with kids than they do with adults, but they all play a role. And we'll talk a lot about kids and breathing when we get to pediatrics. So the respiratory system, like we had sort of talked about already, the air comes into the trachea, it goes down the lobes, down to the alveoli, and that's where the oxygenation takes place. I put this slide in here, so again, if you click on this picture of this young lady here, it will take you to a YouTube video that explains it quite well. So I strongly suggest you take a look at some of those videos. They're well They're well done. Characteristics of normal breathing. So, I mean, we think we know what normal breathing is. We're all probably breathing fairly normal right now, but it becomes a little bit more problematic to actually explain that and try to put that into words. So someone who's breathing at a normal rate, 12 to 20 breaths per minute, is normal for the most part. Depth. So someone can breathe in 12 or 20 breaths per minute, but they're breathing incredibly shallow and their tidal volume is like 100 milliliters. That's not normal. They have to be breathing a normal depth and a normal rate. They have to have a normal pattern. So the regular inhalation-exhalation pattern has to be there. They have to have clear lung sounds. And well, when we get into the respiratory section, we'll talk about all these different types of stridor and wet lung sounds and wheezy lung sounds and all this other stuff. So they have to have a normal rate, a normal depth, a normal pattern, and that when the air gets inside, the lung sounds have to be clear so the air can get down into the alveoli. If you have some type of chest injury, you may not have normal chest rise and fall, which is going to then affect your tidal volume. And then, especially with kids, they're belly breathers. So we're going to see a lot of movement in the abdomen. Adults are much less that. Trying to take someone's respiratory rate can be quite difficult because we breathe at such in such an effortless way that unless you sort of have your hand on their chest or a stethoscope listening, it's hard to really get a good respiratory rate. The problem is as soon as you tell them that you're taking a respiratory rate, try to do that. It's almost impossible to breathe normal when you know someone's listening to you breathe normal. It's just sort of screws up your mind. So oftentimes what we'll do is we'll take someone's pulse or blood pressure, or we just sort of put our hand on their back and talk about something else, but we're allowing them to just maintain that normal respiratory rate and depth as we're sort of timing it out. Okay, so that's adequate breathing, and inadequate breathing is a little bit different, right? So too fast, too slow, too deep, too shallow, irregular, so real fast, real deep, and then a period of apneic, which is no breathing at all. If we see the skin getting sucked in between the ribs, that's called retractions, often seen around the clavicle as well. This is especially critical in children. We usually don't see it in adults because most of us adults have a layer of fat on us that we can't see that, but with kids, they're often very skinny, and retractions are very noticeable. Pale or cyanotic skin. So we'll first notice it maybe in the fingertips, in the fingernails, around the lips area, but that is the buildup of CO2. Cool, damp, clammy skin. So our skin is pink, warm, and dry because the capillaries are full of blood and oxygen. As soon as our body becomes oxygen deprived, our body automatically is going to take that oxygen and shunt it to our core organs, our heart, our brain, our liver, our lungs, and things like that. And the first thing to lose it is usually our skin, because our skin is pretty dynamic and can handle periods of time without oxygenation. So the first thing, it's not going to be warm. It's going to be cool. Why? Because we don't have a lot of blood, not a lot of oxygen in our skin. It's going to become sort of clammy and damp because it sort of becomes that molted, almost pasty type of feeling. Why? Because we don't have a lot of oxygen and blood in our skin. It's going to have that dusky look to it, that bluish flip. Why? Because we don't have a lot of blood in it. We shunted all the blood away from our skin to our core vitals. Usually not a good sign for someone. And then we position ourselves in a certain way. The way the book often describes it as a tripod position. So we're sort of leaning forward, elbows or hands on our knees, trying to arch our back to try to maximize the amount of space in the inside of our lungs to get more air into it. A very common position you'll find people who are having respiratory distress, and should be noted. All right, so how the blood moves throughout the body. There's a really good video. I'm biased about the video because I shot it myself on that clear screen. What's it called? The Glass Studio. But this is sort of the anatomically correct version of that. And there's about 3 different slides here to all talk about the same thing. But let's start down here. So the blood comes into the into the heart through the superior and intervena cava. It goes to the right atrium, through the tricuspid valve, to the right ventricle, through the pulmonary valve, to the pulmonary artery, and then to the lungs where it drops off the CO2, picks up the O2, comes back to the left side of the heart, through the pulmonary vein, left atrium. There's a valve that separates the left atrium from the left ventricle called the mitral valve. And then there's a valve that separates the left ventricle from the rest of the body, and the aortic, called the aortic valve, then the aorta, and then obviously the body. Very quick, right? I understand. Watch the video in a Glass Studio, and I go through it in great detail. Two things to really take note of here. The pulmonary artery, it's the only artery that carries deoxygenated blood. So it's an artery that carries oxygen that has no blood. And the pulmonary vein is the only vein that carries oxygenated blood. Classic test questions I talk about in the video. So here we go. Arteries carry oxygenated blood, except for what I just talked about. Veins carry deoxygenated blood, except for what I just talked about. Capillaries sort of connect the blood to the individual cells. So we have those throughout all of our body. The average adult has about 6 liters of blood in their body at any given time. Children, somewhere between 2 and 3. Infants can have as little as 300 milliliters. So not very much room for error when it comes to infants. We talked about the different artery veins, or the artery locations. That's on page 201. You should definitely know where the carotid artery is. You should definitely know where the brachial artery is. You should definitely know where the femoral artery is and the radial artery. You know where those 4 are, you're probably going to be okay. And then we talk about the absence of distal pulses. So if you take someone's radial pulse at their wrist and you feel it strongly, that is a strong indicator that their blood pressure systolically is at least over 90. If it's sort of thready or crappy or hard to feel, you're probably right around that 90. Once you lose it radially, one of the things is one of my pet peeves with EMT classes is that the student comes in, they try to feel a radial pulse, and the test proctor says no pulse, and then they move right on and just keep on going. I'm like, no, stop. If you don't have a radial pulse, find a pulse. It's part of your ABCs. If you can't find a pulse, you should be starting CPR. We know this. But because the patient's sitting there talking to them, they sit there and they say, well, I know they must have a pulse somewhere. Well, stop. Find it, right? If you feel a carotid pulse at the neck, and you do not feel a radial pulse at the wrist, that's a very strong indicator that the systolic blood pressure is below 90 and probably above 60 or 70. So we have a lot of information. We've gotten a part of their blood pressure without even having to put a blood pressure cuff on them. But it tells us a lot about our patient. They're shocky. They have a bad perfusion, and we need to do something about that. So, enough about that. Talked about that slide. Here's another slide. Same exact thing. Talks about the inferior vena cava, how the blood comes out, a different diagram. Watch the video. Electrical conduction system of the heart. So we have 2 nodes that we need to know about. We have the SA node, which is located up here in the right atrium. It's usually in the upper left-hand corner. That is sort of the impulse. So the heart is driven by electricity, and the electrical impulses start at the SA node. And they push them out, should be at a fairly regular beat. But just in case it's not regular, then it comes down and it has to go through the gatekeeper, which is called the AV node, atrioventricular node. This node here does not generate any electrical impulses. It just allows them through to the rest of the heart, to the pumping chambers down below. But it makes sure that they're coming through on time, in order. Because if the heart does not beat very precisely, it will not work at all. So the SA node should do its job and put them out regularly. The AV node double checks it and pushes it through. Sometimes our SA node fires erratically or just puts out a ton of electrical charges, which we call AFib. You'll have patients all the time who are in atrial fibrillation. Means that this SA node is not working, but the AV node is still working, and it's still only allowing them to come through on time so the rest of the heart can beat effectively. If the AV node malfunctions, well, then you're in big trouble, and then your heart's not going to work, and that's sort of called cardiac arrest. So as it comes through the AV node, it's going to go through your bundle of His. It's going to come through the Purkinje fibers down below here, and then it's going to actually fire the left ventricle or the right ventricle accordingly. So what do you have to know as an EMT? Electrical, that the heart runs electricity. The electricity starts at the SA node. It's double checked through the AV node, which is often called the gatekeeper, and then it comes down through the bundle of the bundle branches, the bundle of His, and the Purkinje fibers. All right, a couple more here I'm going to do 2 more slides here, and then I'm going to end this video because we're approaching a half hour here. So the heart rate is simply the number of beats in 1 minute. We can take a pulse for 15 seconds, multiply it by 4, take a pulse for 30 seconds, multiply it by 2, or we can take the entire 1 minute pulse. It's just sort of awkward to sit there and hold someone's hand for a minute. Stroke volume is the amount of blood that's pushed forward out of the heart with each ventricular contraction. So 1 beat, this is how much blood comes out of my left ventricle. The cardiac output is simply taking the heart rate and multiply it by the stroke volume, which gives me the total amount of blood pushed out of the left ventricle in 1 minute. So it's stroke volume times heart rate equals cardiac output. The systemic vascular resistance, SVR, great test question. Sometimes it can be extra credit, sometimes it can be just put into the middle of the test, but the systemic vascular resistance is how dilated or constricted your blood vessels are. So if you think of a garden hose versus a fire hose, and you have the same amount of water, so we have the same, so say we have 500 gallons of water and we try to shove it into this garden hose, you can imagine there's a tremendous amount of pressure inside that garden hose because we've got to pack all that water in there. So that would be a very constricted vein or artery. Take that same 500 gallons of water and put it into a fire hose, well, it's going to fill that up, but there's going to be way less pressure because there's a lot more room, right? Same amount of blood, same amount of water, different systemic vascular resistance. So we talk at length about how we can manipulate the systemic vascular resistance to help our patient, depending if they have high or low blood pressure. All right, that's where we're going to stop for this video. We're at 30 minutes, and I'll come back and do the second half of this momentarily. Thanks.